Dear colleagues, welcome. This week we celebrate the International Medical Physics Week. And as in previous years, IOMP organizes free webinars. There are no fees, so anyone can register and benefit from the expertise of distinguished speakers. Today, first day of the week, I have the pleasure to introduce two excellent speakers from France, Dr. Marie-Odile Bernier and Dr. Sophie Jacob. They will talk about non-cancer effects associated with low to moderate doses from ionizing radiation. So today's webinar will provide an overview of recent epidemiological results with a special emphasis on medical application of radiation. The first speaker is Marie-Odile Bernier. Marie works in the Epidemiology Department of the IRSN. IRSN is the French Institute for Radiation Protection and Nuclear Safety. She's coordinating epidemiological studies on low-dose exposure in the field of medical exposure at IRSN. Marie has launched a large cohort specifically designed to study cancer risk in 100,000 children exposed to CT scan in France. Dr. Bernier is an experienced researcher and clinician. She has more than 25 years of experience as endocrinologist, specialized in the treatment of thyroid cancer. I also have the pleasure to introduce Sophie Jacob. Sophie received a master's degree in mathematics and biostatistics for biology in 2004 and a PhD in epidemiology in 2007 from the University of Paris. Since then, Sophie is a radiation epidemiologist at IRSN. She's specialized in non-cancer effects of ionizing radiation. Sophie has coordinated several research projects such as the French O'Clock study on radiation cataract and lens opacities, and has been involved in the Opera Uraloc study, in the Baccarat study on radiation-induced cardiovascular effects after breast cancer radiation therapy, and in Medirat projects. So without any delay, I would like to ask Marie-Odile to start. Now the number of participants is almost 900. So I guess we and more than 100 chats, messages already. So Marie, the floor is yours.
Okay, thank you very much. I try to share my screen first. I think can you see my screen?
Yes, we can see it in presentation mode, so it's fine.
Okay, so ladies and gentlemen, good day. Thank you, John, for the introduction. So I want first to thank the organizer for the invitation to talk about what we know from epidemiological studies about the radiation-associated risk of non-cancer disease. So I will share the presentation with Sophie, who works also in my lab. I will present studies in the field of neurological diseases, and then Sophie will present the studies about cataract and cardiovascular disease. So briefly, as you know, the annual exposure of the population to ionizing radiation is in average of 0.57 millisievert, but can reach 1.6 millisievert in high-income countries. Half of the dose comes from natural exposure, cosmic radiation from Earth and radon gas, but half of the dose come from medical imaging. It's an artificial origin, and it's a very large source of exposure of the general population, especially in countries with high incomes. So medical imaging has become an essential tool in medical practice, and the use of imaging procedure, especially CT scan, has dramatically increased since the 80s, as you can see on these graphs. And CT delivers much higher doses than conventional radiology procedures. Furthermore, patients may be exposed to repeated imaging, so it's really important to study the risk associated with the cumulative dose received. We already know that high dose of ionizing radiation for more than several grades are a very well-known risk factor for cancer. And at lower doses, even under 100 millisievert, many studies, many epidemiological studies have demonstrated increased risk of cancer, as in the nuclear workers cohort studies, but also in cohort of children exposed to CT scan. Concerning radiation-associated non-cancer disease, they have been firstly observed in the field of deterministic effects. I mean, effects that are specific, for example, cardiac fibrosis, and that appear above a certain threshold, often of tenths of gray. But what about the risk for lower doses? For lower range of doses, I mean less than 1 gray and even smaller than 100 milligray, less information is available. However, since the last 20 years, several epidemiological studies have reported vascular disease and cataract risk for moderate to low doses, with some studies providing even the form of the dose-response relationship. However, there's still a lot of work to better assess these effects, to take into account other risk factors, but also modifying effects. And we need also to better understand the underlying mechanism. So for neurological diseases, there is only sparse literature available for effects at level of dose of low dose and moderate dose. And because of the lack of convincing evidence, non-cancer risk at low doses have been considered recently as a priority subject of research at international level, as it is stated in the strategic research agenda of MELODY, for example, an European platform of research in the field of low dose. So I will now present the risk of neurological diseases associated with low to moderate dose of ionizing radiation. So just a bit of context. So the central nervous system or CNS disorders cover, in fact, a very large and heterogeneous panel of diseases. We can consider two main groups. First, the mental and behavioral disorders that affect 13% of the global population. And in this group, we have very different diseases as depression, but also psychotic diseases like schizophrenia, and also like disease like dementia. The second group is composed of disease of the CNS, affecting 36% of the global population. It includes degenerative disease as Alzheimer's disease, multiple sclerosis, but also brain tumor and strokes. So a lot of people are in the field of this kind of diseases. So studying CNS disorder in epidemiological studies is quite a great deal because we have several methodological limits. First, the diagnosis can be difficult to assess when it's based on death certificate or on various clinical tests that are not always standardized. Sometimes the disease can also be underreported, especially in countries with low level of income. There is also a potential of misclassification for the disease in one of the two main subgroups. For example, the Alzheimer's disease is classified as CNS disease group, but dementia resulting from Alzheimer is classified as in mental disorder. So it can be sometimes a mess when you work on the death certificates. Another issue is the multi-factor aspect of this disease. The associated risk factor that can be very different for each specific disease are not always easy to collect in a large group we need to our epidemiological study. So, and even it's difficult, for example, like if it is psychological trauma or toxic factors. So in my first part, I will speak about mental and behavioral disorder, and I will speak about cognitive impairment. It has been studied in prenatal and childhood exposure, and it has been observed in children irradiated during nuclear disaster, because in this case, all the population is irradiated, including pregnant women. So in the follow-up of atomic bombing survivors exposed in utero, it's about 1,000 people concerned. It has been shown that for fetal dose in the range of hundreds millisieverts during the first and the second trimester, an increased risk for morphological birth defect, as for example microcephaly, has been observed. And the critical period seems to be the 8th and the 16th week of gestation during the period of growth and maturation of organs. At lower doses, the studies on Chernobyl health consequences can give some clue. And it has been observed reduced school test results and decrease of IQ level in children born in contaminated areas. In the medical field, we have a few studies. We have two studies, two cohorts, very interesting, that evaluated IQ at 18 years during military service. And they have been correlated with exposure during childhood to moderate dose of ionizing radiation for therapeutic purpose for head cutaneous hemangioma and for tinea capitis. Both cohorts observed decreased IQ for irradiated patients. But they are quite old studies because they were the patients were treated in the 50s. So recently, there has been one study on cognition after exposure to CT, and they observed no difference of cognition between children exposed or non-exposed to CT. But the sample of the study is very small. So if you can find more detailed information in the recent systematic review from Pascal and al. That had been published in 2020, and they retrieved 26 studies focusing on exposure to moderate to low dose during pregnancy and childhood. And they retrieved 26 studies and performed a critical analysis of the reported results with special attention to potential bias and level of confidence in the result published. So they only found 5 studies with dose response assessment from the atomic bomb survivor cohort and from the hemangioma cohort study. And they conclude that this study indicates a decrease in cognition associated to an increase in radiation exposure of approximately 0.15 to 0.2 IQ point for each 100 milligram of dose. But they could not perform a quantitative assessment of the risk because of the heterogeneity across studies. They could not pull together the studies. And the overall conclusion of the paper was not so good, because they said they limited to inadequate evidence of an effect of low to moderate ionizing radiation dose on neuro development. So concerning adult exposure, results from the follow-up of atomic bombing survivors did not show any risk of dementia after adjustment on other risk factors. And in contrary, some cognitive impairment were observed in study on cleanup workers in Chernobyl disaster. But the findings are limited by potential bias linked to the impact of other risk factors like stress post-disaster, and also small sample size of the study population. So we can have some information from radiation workers cohorts, because the advantage of these studies are that there is usually good assessment of dosimetric exposure and also larger samples of population. For the nuclear workers, we have the in-work cohort study that is a joint cohort or 3 national cohorts from US, France, and UK, representing more than 300,000 workers individually monitored for external exposure to radiation. The vast majority of them were men, and the follow-up was based on mortality assessment in each cohort. At all, they observed 21.6% of deaths in the study, with 705 deaths by mental disorder. And in this death, the dementia represented 53% of the deaths. And for the category mental disorder, the authors reported a significant increased excess relative risk per sievert equal to 1.3, considering the cumulative dose lagged by 10 years. And age, sex, and socioeconomic status were the only other risk factor associated. The limitation of the study include a follow-up based on mortality, and as I said previously, the mortality is not the best way to assess CNS disorders. And also we have a large percentage of men. That means that we cannot really look for women if the risks are similar. So in this table, you can find a summary of other studies in radiation workers which observed significant impact of radiation on mental and behavioral disorders. In the group of nuclear workers, decreased risk of death by mental disorder compared to the general population were observed in US and German cohorts. In contrary, an increased SMR was reported in the Czech minor cohort, and also in a case control study nested in the cohort of female worker of a nuclear plant in the US. For the Chernobyl disaster, there have been increased risk of mental disorders in workers exposed to more than 50 millisieverts compared to workers exposed to less than millisievert for psychosis and not psychotic damage. And for medical workers, a decreased risk of mortality compared to the general population was observed in the study published by Boyce in 2021 on about 60,000 medical workers. And the last study is a study that compares physicians likely to have performed fluoroscopy guide interventional procedures, and they compare them to psychiatrists. And they observed a significant decrease of risk compared to the psychiatrist. In all these studies, the decreased risk observed when comparing to the general population can be linked to what we call the working health effect. Classically observed in occupational studies, it means that the health state of workers is better than the health state of the general population. The lower risk observed in the study about clinicians compared to clinicians that performs FGIP compared to psychiatrists might reflect some bias in the population sample or impact of other risk factors. So the second part of my talk will be quicker because it's really a so large group of diseases that I decided to focus on one disease, the Parkinson's disease, that is well known and for which we have some interesting recent results. So the incidence of the disease is 11 to 19 per 100,000 people per year in Europe. It's a progressive nervous system disorder manifesting as a reduced facilitation of voluntary movement, and it is linked to the loss of dopaminergic neurons. There are some risk factors like age, sex for men, and heredity, but also suspected environmental factors. So there has been published a very interesting study in 2019, a study from Azizova and al. About Parkinson's disease incidence in nuclear workers at the Mayak facility. So a cohort of more than 22,000 workers have been followed since 1948 until 2013 with annual clinical checkups. And the mean age at the end of follow-up was 62 years at death and 69 years for those alive. They reported 300 cases of Parkinson's disease, and they reconstructed the brain cumulative dose due to external gamma rays, and the mean dose was about 460 milligray in men and 360 milligray in women. They were able to adjust for several risk factors as sex, age, body mass index, but also personal medical history. And you can see in the table that there is an increasing relative risk of Parkinson's disease with increasing the dose. And the risks became significant when the dose was equal or above 500 milligray. And if you look at the shape of the relationship, you can see that this seems to be a linear relationship between exposure and risk of Parkinson's disease. And an excess relative risk per grade has been calculated, is estimated to be 1.02 and is really significant. So there's 3 more studies on this subject published recently from the US. And they did not observe a significant association of Parkinson's disease with the received dose, except in the Los Alamos laboratory worker study, in which the association is borderline. However, in all these studies, the number of cases is much lower than in the Russian cohort, and the mean level of those was also much lower than in the Maya cohort. So in conclusion, we can see that it's really not an easy task to study CNS disorders in radiation epidemiology for low and moderate doses, because there's methodological issues for the assessment of case, but also to study the impact of other factors. There is many factors to consider, and so it's really difficult to obtain this information for each individual when we need large cohort study. So we have now very few studies with dose-risk relationship, and we have some inconsistent results with some studies showing positive result and other negative. So the role of low-dose ionizing radiation in CNS health deterioration is possible, but still unclear. And so we need to develop new study with a very good design, and also continue to the follow-up of workers, cohorts, and also of Japanese IOMP survivors to have more idea of what is really the impact of radiation on CNS disorder. So I think I'm finished now, and I will give the man to Sophie to present other topics.
Thank you, Marie-Odile. Can you unscale your and share your screen? Yeah, thank you.
It's okay?
Not yet.
Okay.
Okay. Okay. Can you see it?
Yes.
Yes, yes.
Okay, so now let's move from other type of non-cancer effect with first lens opacities and cataracts. So lens opacity is the principal pathology of the lens, which is labeled as cataract when it is more pronounced. And this is the first cause of vision loss in the world. There are different types of cataract according to the localization of opacities in the lens, and the most frequent type of cataract are nuclear, cortical, or posterior subcapsular cataracts. And there are several risk factors for these cataracts: age, of course, but also exposure to UV radiation, also diabetes, high body mass index, smoking, corticosteroids use, ocular trauma, genetics, in particular for congenital cataracts, and also ionizing radiation. As a diagnosis of cataract, the gold standard is based on an ophthalmologic examination, which is based on a slit lamp examination after pupillary dilatation. And then you can code the cataract according to the type and the stage of the cataract. But what is difficult is that there are different classifications of the cataracts, which are quite similar, but not exactly, in particular for the Merriam-Focht classification, the LOX classification, the WHO classification, etc. What happened in 2011, it's the threshold, it was considered as a deterministic effect, and the threshold has been decreased based on results from epidemiological studies, and the ICRP had a statement on this particular tissue reaction, and they consider finally that the threshold for lens opacities was 0.5 gray, and for occupational exposure it was decreased from 150 millisievert per year to 20 millisievert per year. And the year after, there was a big publication of the ICRP, publication 118, and for cataracts, the conclusions were as follows. So they separated acute exposure, fractionated and protected exposure, or chronic exposure. For acute exposure, they considered that the value for the threshold was approximately 0.5 gray, but without excluding the possibility of no threshold. For fractionated or protected exposure, again, that was 0.5 gray. And for chronic exposure, they finally decided that we could keep a 0.5 gray for minor lens opacity more than cataract, in fact. So I'm now going to present several studies, epidemiological studies that were published after this ICRP publication, illustrating that the struggle is still on debate now. So the first large occupational cohort is the MAIAC workers cohort. It was published in 2018 by Azizova and colleagues. It included more than 22,000 workers with very long follow-up of 22 years. They performed a slit lamp examination in order to have a lens opacity classification. The gamma dose, mean gamma dose was 0.5 sievert for men and 0.4 sievert for women. And in this study, they could observe a dose-response relationship for the three types of cataract. That means for posterior subcapsular, for cortical, and for nuclear cataract, with an increasing risk according to the increasing dose. Oops, is it okay? No. Okay. A little more recently, they again performed on this big occupational cohort analysis for cataract surgery, not history of cataract surgery. And in fact, in this analysis, they could not observe this time a significant dose-response relationship. So that was a little bit different from what was observed for cataract history. Another large cohort is the US cohort of radiological technologists that was published by Mark Little and colleagues. It included more than 60,000 technologists with a mean follow-up of 12 years. The lens dose was based on work history and badge monitoring. And the mean dose for the cohort was 55 milligray. And for cataract assessment, it was based on self-report. In this study, they evaluated the risk of cataract history or the risk of cataract surgery according to the level of exposure. And you can see here that they observed a higher risk of cataract history with higher doses. But for cataract surgery, the dose response was less clear. They also evaluated the excess risk per gray according to the range of exposure. And what is interesting is that you can see here for cataract history, even when they limited the population to people receiving less than 200 or even less than 100 milligray to the lens, they could observe in this population a significant dose-response relationship. So the association is still true for cataract, even with a dose range below 200 or 100 milligray. In this cohort of radiological technologies, Marie-Odile Bernier, who is here, also published a paper focusing on technologies working in nuclear medicine with nuclear medicine procedure. And what was observed in this study is that this concerning cataract diagnosis, there was a higher risk of cataracts for these technologies compared to unexposed technologists, both for cataract diagnosis and cataract surgery. And when they analyzed separately people working with diagnostic nuclear medicine procedure or therapeutic nuclear medicine procedure, they also observed a significant excess risk of cataract diagnosis, but not for cataract surgery. Another interesting study, which is also a bit older, is a study that was published on patients exposed to head CT. And it's a study that was performed in Taiwan, and they compared a group of patients exposed to head CT to a non-exposed group. And again, for cataract, they observed a higher risk of cataract in exposed patients compared to unexposed patients, in particular for patients who had received more than 5 CT, corresponding more or less to 250 millisieverts for these patients. Several studies were performed in the context of medical exposure for interventional and radiologists and technologists, sorry. And as you can see here, there are several studies. They compare the risk of cataract in interventional radiologists versus a control group. And all these studies provided results in favor of an increased risk of early posterior subcapsular cataract. And a European cohort was developed a few years ago. It's a EuroLoc study, which included 11 countries, and they included nearly 400 interventional cardiologists and a control group. The median lens dose in the study was 150 milligrams to the lens. In this study, could observe an increased risk of posterior subcapsular cataract in the exposed group versus non-exposed group with an odds ratio of more than 2, and also a linear dose-response relationship without result with an ERR per gray of 1.3. These results are still not published, but you have it. So to conclude for this first part, so radiation-associated excess risk were observed for both posterior and cortical cataract. For nuclear cataract, they may be in fact less radiogenic. For ICRP, based on publication 118, it was cataract were classified as a tissue reaction effect with a threshold of 0.5 gray, below which there would be a minimal excess risk. However, several findings, as I have presented, showed there is a significant excess risk, even under 500 milligray or even under 100 milligray. So the evidence and the level of threshold is still debated for cataract, but also there are some challenges, dosimetric issues and epidemiological limits that should be taken into account in future study to further develop knowledge in this field. So let's move now to the circulatory disease. So this is the dominant cause of death in many developed countries. There are two major groups of circulatory disease, cardiovascular disease and cerebrovascular disease. And in particular, among cardiovascular disease, ischemic heart disease were particularly studied because it's circulatory disease is an inflammatory process involving probably atherosclerosis, which is underlying ischemic heart disease and cerebrovascular disease. For this circulatory disease, there are several risk factors, age, of course, but also diabetes, smoking, hypertension, high cholesterol level, high BMI, and also ionizing radiation. For the diagnosis, there are several examinations that are possible, just an electrocardiogram, but also echocardiography, cardiac CT, cardiac MRI. And some studies also worked on the codes for medical registries for the Oui?
Sophie, I'm sorry to interrupt, but we are still on cataract summary conclusion. Yes, it changed now.
Because I have two screens, in fact. Is it okay?
Yes.
Okay, thank you, Marie-Odile. Okay, so you have ICRP now?
We are on circulatory disease.
Okay.
Yes, on ICRP now.
Okay, so I have to check my two screens. So what is the position of ICRP in publication 118 for circulatory disease? They stated that from current evidence, a judgment can be made of a threshold for acute doses of approximately 0.5 gray for both cardiovascular disease and cerebrovascular disease. And what is also important here is to know that at the moment, there is no difference in the level, in the threshold, that in the case of acute fractionated or chronic exposure. So we speak about at 0.5 gray, whatever the type of exposure. So since this publication, several studies were performed, And the first one among others, on a large occupational cohort of nuclear workers in work studies that included more than 300,000 workers with a mean follow-up of 25 years. They evaluated the risk of ischemic heart disease and cerebrovascular disease mortality. The mean cumulative equivalent dose was 25 millisieverts. And you can see that when they evaluated the risk of circulatory disease, they could observe a significant dose-response relationship with increasing dose, with a dose range with significant risk below 300 millisieverts. And for ischemic heart disease and cerebrovascular disease, they also could observe a significant dose-response relationship with dose range with significant risk below 500 millisieverts for ischemic heart disease and below 100 millisieverts for cerebrovascular disease. Another large cohort of MAIAC workers published by Azov and colleagues in 2015, which included more than 22,000 workers with a mean follow-up of 35 years. They evaluated the risk of ischemic heart disease and cerebrovascular disease in terms of mortality and morbidity. The mean dose to the heart or brain was 0.6 gray for males, 0.5 gray for females. And in this study, they could observe a significant dose-response relationship for ischemic heart disease morbidity and also for cerebrovascular morbidity. However, when they evaluated the risk for mortality, there was no longer a significant dose-response relationship. And also they could observe a slight difference between males and women and females. Sorry. And in the same cohort, they recently published another study focused on cerebrovascular morbidity. And they could conclude that cerebrovascular disease incidence was found to be significantly associated with cumulative radiation exposure, with an excess relative risk of 0.37 for males, 0.47 for female. And well, yeah, that's it. You have here the form of the dose-response relationship. So a significant association, dose-response association for cerebrovascular disease morbidity in this study. Another important study is the lifespan study, and a recent study published on more than 86,000 individuals with a mean follow-up of 40 years. They evaluated cardiovascular disease mortality and could observe that for heart disease as an overall, there was a significant dose-response relationship. But what is very interesting in this study also is to see that among the different types of heart disease, there are also some difference in the strength of the dose-response relationship. You can see, for example, here that for vascular disease, the risk is very high, whereas in this study for ischemic heart disease, the risk was slightly lower. So even among heart disease, there are some discrepancies, some difference between the different type of heart disease. In the field of medical exposure, two big studies were performed on the tuberculosis fluoroscopy cohort for patients in Canadian cohort and the Massachusetts cohort. And these both cohorts were pooled and published recently by Tran and colleagues, which included more than 77,000 patients with a follow-up of 25 years, and they evaluated the mortality. And they could observe that even for patients with dose below 0.5 gray to the heart, they could observe a significant dose-response relationship that was true for all circulatory disease, but also specifically for ischemic heart disease, but it was no longer true for cerebrovascular disease, below 0.5 gray. I would like very briefly to speak about its for higher doses, but I think it's important also. This study published by Darby and colleagues for breast cancer patient treated with radiotherapy, which included more than 2,000 breast cancer patients treated with radiotherapy, and they evaluated the risk of acute coronary events. So the mean dose was quite high, it's nearly 5 gray, but it's interesting also because they could observe here again a significant dose response relationship for this population. And in the context of radiotherapy and breast cancer patients, the European Moderator project developed 2 studies. The first one was the BRACE study, which was a retrospective cohort of more than 3,000 breast cancer patients treated with radiotherapy. In this study, they could evaluate the risk of acute coronary events, but also arrhythmia, conduction disorder, heart failure, etc. The mean follow-up in the cohort is 9 years, and the results should be published this year, at least for acute coronary events. And in Moderator, another study, the earlier study, which is this time a prospective cohort of 250 breast cancer patients treated with radiotherapy. In this study, we evaluate cardiac changes arising within 2 years after radiotherapy, so it's very early changes, quite early changes. All patients have echocardiography, cardiac CT and CTCA, cardiac MRI. And again, the results should be published this year and the year after. If you want to have further details and several recommendations for the Moderator project, you can see on this on the website of the project. And so to conclude, concerning circulatory disease, as I said, for ICRP publication 118, it has classified circulatory disease as a tissue reaction effect with a threshold of 0.5 gray, below which there would be a minimal excess risk. However, again, several findings showed that there is significant excess risk under 500 milligray. In this publication by Mark Little and colleagues in 2016, they performed a meta-analysis and evaluated the excess risk per gray based on several studies from low doses to higher doses, and could evaluate a significant dose-response relationship for both ischemic heart disease and cerebrovascular disease. And the paper concluded to strong evidence in support of a causal association between both low and high dose radiation exposure and most type of circulatory disease. So, but the evidence and the level of the threshold for circulatory disease still debated, and last year, two task groups, 2 expert groups were launched. In ICRP, the task group 119, effects of ionizing radiation on disease of the circulatory system and their consideration in the system of radiological protection that should, in 2025, provide a new report of ICRP on the topic of circulatory disease. And an expert group of UNSCARED, the CircuDis expert group, evaluation of disease of the circulatory system from radiation exposure, that should also provide a report in 2025. That was my last line, and I give for the last slide, give the floor to Marie-Odile to conclude.
Thank you, Sophie. So in conclusion, what can we say? I think there's a clear evidence of assessment of radiation-associated circulatory disease and cataracts to low doses of radiation, as Sophie showed us some very interesting results. And we have dose response analysis in several populations. And even in impact in terms of radioprotection, there have been already a recommendation from ICRP to decrease the level of cumulative dose for the lungs for workers. So I think we have really something new in this area. For neurological and mental diseases, I am not so optimistic. I think really from the literature that the role of low dose is possible, but still unclear. And there is maybe more methodological issues, and as I previously presented them. And so we need to launch new study with a large sample of people and with clinical exams. It's not always the best way to work on these certificates. And also we have to continue to follow up the cohort we already have. And there was a question about what are the new studies to be launched to better study this kind of risk. And I think that medical cohorts can be a good way to study this non-cancer risk, even if we have to be careful with the indication of the exams that can be also linked to the outcome we study and be a confusion bias. So it's not easy. So
Thank you.
Thank you for your attention.
Thank you, Marie-Odile. Thank you, Sophie, for your excellent presentations. We have some questions and only 8 minutes, so I have to prioritize them. The first question was to you, Marie, from an anonymous attendee. He or she asks, what level of radiation have the children in Norway and Sweden received from the Chernobyl to, this is associated with the reduction of cognition. So do you have any data in mind?
Yes. In fact, there was small doses of radiation because it was not more than 1 milligram in Norway and 4 milligram in Sweden. So they were quite small. And for prenatal exposure in Ukrainian people, we have a level of doses about 17 milligram only. So it's quite low.
Quite low, indeed. And then there is another question from Mikhail Osipov. He is thanking you and asks, in your opinion, are low-dose non-cancer effects the result of local tissue reactions or a general response, system response of the irradiated organism? And Mikhail, I understand that he asks this question also to understand what dose should be, what should be used for radiation risk calculation, if the reference dose can be used to compute the low dose non-cancer risks.
So I don't know, Sophie, if you want to answer. I think epidemiological study can give us a clue for the mechanism involved in the effect we observe. We observe the effect and we have to work in collaboration with biologists to better know what the mechanisms are. So I think we need to have more biological data, and epidemiological studies can answer really to this question. I don't know, Sophie, if you agree.
Yes, I agree totally.
And concerning the dose, so I think it depends. If we have a medical exposure of the head, for example, a CT scan is very important to reconstruct the dose to the brain. But if we follow people exposed from atomic bombing, the irradiation is for all the body, and usually we use the colon dose to estimate radiation risk associated.
There are also some questions for Sophie, but before going to Sophie, at least they were expressed during Sophie's presentation. But before going to Sophie, I think we still have time for one more question to you, Marie-Odile. The next is from Salwa Boutayeb. What does SMR stand for? There was an abbreviation.
I answer in the chat.
Oh, already.
I'm sorry not to have time to.
Yeah. It's okay. It's fine.
Okay.
You have already answered it. Then going to Sophie, a question from Yakov Pipman. As the atomic bomb surviving population decreases, what is the main expectation for the new studies? The number of people, still.
Yes, of course, we can't. The atomic bombs, the lifespan study provide very important information from an epidemiological point of view, but yes, the number of people is now decreasing, and at the moment we don't have such big situation. Maybe that for Fukushima population, it's a new population that is now starting to be investigated, but you need a long follow-up before observing the events. So I guess that in the next years, this kind of population will be also investigated. For the lifespan study, it's true that in the decades or many decades, it will no longer be possible to study this population.
Mm-hmm.
Yes, but you can say that we have still a lot of information from the follow-up of atomic bombing survivors, because there are still people alive, and there is a very good follow-up of the people with clinical tests also. So
yeah, there are.
Yes, at the moment it's still a very important epidemiological study, and there are several studies that are performed on this population for many years again. Sure.
I guess there is still a lot of information in researchers' hands. They are still analyzing data, so we can expect that some publications will be published, some articles will be published in the future on those topics. And the next question, Mamutsu Balde is thanking you, Sophie, and asks how the eye dose is measured for medical imaging workers. How can those be measured for interventional, for example, radiology personnel?
What is now developed is specific eye dosimeter, but I don't know if they are used in routine at the moment. So what is done in many studies, they use the dosimeter which is worn above the lead apron. But in some countries, unfortunately, the dosimeter is worn below the lead apron. So it's not a good proxy of the exposure of the eye. So it's not always so easy to evaluate. What was done in the studies performed on interventional radiologists, it is based on questionnaires to have a very detailed description of the activity for the fluoroscopy-guided procedure, for example, and several studies were performed to evaluate the mean dose that could be received to the operator when performing a coronary angiography, for example. So it's a combination of what is declared by the workers, the description of occupational activity, and also what is evaluated by dosimetrists in terms of mean dose according to the type of procedure. But we can also hope that in the future, more and more people will use eye dosimeter, which is worn on the glasses, so it's not so complicated. And I think it's a good point for future studies to have a precise evaluation of the eye exposure.
Mainly thermoluminescence dosimeters or optical dosimeters have been used, I think, to measure the eye dose.
But at the scale of a big cohort, it's not always easy to be sure that everybody has worn this kind of dosimeter. So it's we have to deal with all this problem. On a small course, that could be possible, but on a big cohorts.
Oof, it's time to close. I am afraid the topic is extremely interesting, and this discussion could be endless, but we have to close. So I would like to thank both of you for your very interesting presentations, and also the audience for their active participation. We had more than 1,100 attendees, so it was a very popular topic for us medical physicists. Yes. Thanks a lot. See you tomorrow.
Bye-bye.
Bye.
Bye-bye. Bye.